evaluator at USET. We have started recording, so the session is being recorded. If this is your first time joining us, which I don't think it is for anybody, please share your name, email, and affiliation and title in the chat. If you're joining us by phone and aren't already on our list, my email is efield, that's EFIELD, at usetinc.org. If you send me an email, I can make sure you're added to our future communications. If you haven't done so already, I'm going to invite you to mute yourself. And please don't take offense if you get muted during the presentation unless you're the presenter. And towards the end of the meeting, I'm going to share an evaluation link in the chat. If you fill it out, it's 4 questions, really quick. We use it to improve these sessions. And that is all I have.
Great. Thank you, Emily. We'll start today with Christy Duke giving her updates.
Thank you, Brian. I appreciate it. As you know, we didn't have this echo session last week, so we'll be updating the rates and the numbers, comparing it to 2 weeks ago, at least for the testing numbers in the Nashville area. Next week's echo session, we'll have the update as normal, but Dr. Brown is going to give an update on all of the new antibody tests that are coming out. There is an additional antigen test that's come out, and there's some new research on the Abbott ID tests. And so he'll be giving updates on just the different testing modalities that are out there, and offering some information to update what we previously put out there. So we're looking forward to that presentation. Just to let y'all know, I do have some groundbreaking epidemiological evidence about the cause of COVID-19. For those of you who don't know, I am holed up with my entire family, including my sisters and my nephews, at my dad's house in Montana, and my oldest sister is single-handedly to blame for COVID-19 and messing up my nephew's life. So there you have it. It's not from China. It's not from anywhere else. It is all my sister's fault. So blame her. All right, we'll go ahead and get started. It looks like we've got a little bit of a delay going on, so my apologies. It'll take just a second. Yes, it is from my sister. And I will tell you, she's also been listening to a very interesting podcast, This Week in Virology. Apparently, I have not started listening to it, but she finds it very interesting. So I'll pass that bit of information on. I'm not sure where she's getting it, but I think if you Google it, you'll be able to find it. So let's start out with our testing numbers. We have seen an increase in testing this week, and this is compared to 2 weeks ago. So you're going to see a large jump in those numbers. So we tested just shy of 12,000 people, and that's up from 9,200 from 2 weeks ago. We have seen a positive increase of about 200 people who have tested positive for COVID-19, and our negative tests are 9,812 compared to 7,568 from 2 weeks ago. We are running about a 13% positive rate. That is not a population rate or rate of prevalence rate of COVID, or excuse me, cumulative incidence rate of COVID. It's just simply the percentage of positives of those tested. So that is about 13% for the Nashville area that we're seeing. And it's been fairly consistent. The cumulative incident rate, and again, this is calculated from state data. It is not tribal data, but we're looking at the USET, the CHISDA counties, the USET states in the United States. We have been consistently higher in our CHISDA counties at 129.93 per 10,000, and compare that to the United States, 91 per 10,000. So we are seeing an increased rate of COVID-19 both within the 13 states that make up the Nashville area and the USET county rate. I do want to remind you that we do have the REDCap tool available for surveillance. Should you need this, we've had, I believe, 8 to 10 tribes taking advantage of this and using this for both case tracking and or contact tracing. We have that built, we have that available. Just contact us at usetepi@usetinc.org and we can get you set up. This is a tool that we've provided at no cost to you. We can modify the instrument if you would like it modified. We have provided several modifications to different tribes. So just a reminder that that's out there if you would like that. And with that said, I will pass this back to Brian.
Thank you. And we'll move on to Dr. Johnson.
Hi, good morning or afternoon for some of us. I see I still have some of the audience, at least one person I know that was with my talk 2 weeks ago when I gave a talk on COVID. I do want to give the disclaimer or understanding that the talk a couple of weeks ago was designed for our healthcare providers. Today I changed the talk to a different audience, and so you'll see something that's a little different from what you saw a couple of weeks ago. So
You're muted, Dr. Johnson.
Oh, wow. So I did a whole introduction for nothing, huh? Good morning, everyone. Hi. Wanted to begin by letting everybody know I see that I have some of the same audience I had 2 weeks ago, and I wanted to just let you all know that today's talk will be a little different. It's aimed at a different audience, and so if you heard my talk last week, you will at least get to hear something different this week. It'll be on a level that's not specific for healthcare providers. Today, our objectives, we'll talk about lung disease associated with COVID-19. I know now we've been in this pandemic for several months now, and so there's a lot of information that's out there related to COVID-19, but I just wanted to talk about a few things related to lung disease, and also talk about some things that we can do for follow-up with those patients with COVID-19 to help them along with their diseases, and some of the things that we can do to help prevent them from getting into a severe state. So today my targeted audience will be, again, the general public, your community health techs, anyone that's going to have contact with your COVID-19 patients who aren't healthcare providers. That includes some of our public health workers who may be in contact with them with tracing or other things, just people who are friends and families taking care of COVID-19s, as well as, you know, in general, we can use some of this for our own safety and care should we, hopefully not, but we come in contact and develop COVID. So COVID affects the major target for COVID are your lungs. You hear about people who get pneumonia, who end up in the ICU on ventilators. And when the virus is inhaled into the lungs, it invades the tissues and causes a huge inflammation. And that's why people usually have the breathing problems that you hear people say, oh, I feel like if I walk, I can't breathe, I can't catch my breath. And that's because it affects the respiratory tract. In the human body, there is an upper respiratory tract and then there's lower. You can see where my circle is. That's the lower respiratory tract. And what happens is the virus gets into the body, it comes in contact with your mucous membranes that line your nose, your mouth, and your eyes. It enters your cells and it starts to duplicate or replicate and make new viruses. Again, it can affect either the upper part of your respiratory tract, or it can also travel down into your lower respiratory tract and affect your lungs. But in the process, it inflames all of this. So you see it inflamed and swollen, and that's why people are having problems with breathing. When you look at the pneumonia that's associated with COVID-19, you see something that's on your chest x-ray or your CAT scan, and we call it ground glass. And I wanted to show this picture so that everybody would kind of get an idea of what ground glass looks like. Ground glass looks like frosted glass on a shower. You can see here where you have your clear glass and then you see that ground glass. That's kind of what happens when you get the pneumonia part of it. Your patient symptoms, as we all know, patients have that cough, they have that, say, I'm having problems breathing, I feel like I can't catch my breath. If they have a pulse ox and you're checking their pulse ox, you're getting oxygen levels that may be low. And one of the things that's really concerning, and we'll talk about that later on, is that a lot of patients who say, I'm just extremely tired, extremely fatigued, and they associate that with just a part of having flu-like symptoms or having COVID. A lot of times those patients actually will have low oxygen levels, and those low oxygen levels are what's causing them to be severely fatigued and tired. And that's one of the reasons why I started pushing for those who have COVID diagnosis to actually have a pulse oximeter at home to help as a part of their management of their disease. So we all know that patients that have COVID have a pneumonia, and I wanted to show you what what pneumonia really is and why it causes such a problem. If you can see where my little marker is, these are your lungs, and these are the little sacs that fill up your lungs. All throughout the lungs, you have these little sacs. And what happens with COVID-19 is these sacs start filling up with fluid. And that fluid can, of course, prevent you from getting the normal oxygen levels that you need. And patients develop shortness of breath and what we call ARDS. Some of those patients end up on ventilators for long periods of time, and they recover. But a lot of those patients that end up in those long courses and end up on ventilators actually have some lasting pulmonary disease or scarring, and it takes them a very long time if they actually recover. So I just want to show you some imaging of the lungs. On this right-hand side, this is what your normal lung looks like. You can see some little lines or whatever associated with the lungs, but you don't see a lot of disease. If you look at this chest x-ray on the left, you see a lot of whiteness. You know, we talked about that glass, that foggy glass. That's what these lungs are looking like, and that's when they talk about the pneumonia. Probably 85 to 90% of the time, it's not just in one lung, it's in both lungs, which is really unique because most pneumonias just affect one lung. When you look at the CT scan, I wanted to bring this out because, you know, I know a lot of times when people are getting care, they wonder what someone else got and why they didn't get that particular imaging or that test done. And I wanted to mention that with CAT scans, if you hear about people who are getting CAT scans, usually we don't recommend that patients get CAT scans. And the reason why is it really doesn't make a difference. The only time that you really want to order a CAT scan is if you're wondering if the patient may have a pulmonary embolus or other reasons to get a CAT scan. But again, when you're using when you do the CAT scan, you're not only putting the people who are doing the test at risk of contracting the disease, but you also put the patient at risk of decompensating while you're transferring that patient to a CAT scan because you don't have the same medical team available. And so we really don't recommend CAT scans normally in COVID unless you're looking for something else. And again, a lot of times in the first few days, the CAT scan is going to be normal anyway. Remember how I talked about that frosted glass? Well, this is what you're seeing on your CAT scan. If for some reason you get a CAT scan, this is normal lung, and this is the CAT scan, the ground glass. This is the ground glass that we talked about, that frosted glass that we'll see on the CAT scan. And I want to show a few more images so you can kind of get a chance to see what you're seeing on CAT scan with that frosted glass / ground glass. and it progresses as time goes on. That's maybe early on, and then as time goes on, it gets worse, and the lungs start sticking together, if you will. And then that long-term disease is what we call the fibrosis of the lungs, when they get the really bad scarring in the lungs. And this is a normal CAT scan of the chest. And here's all this scarring and fibrosis that is associated with lungs. And these patients, unfortunately, they don't really recover and develop normal lungs. This is not reversible. And so our goals are to prevent patients from getting so bad that they will actually have that long-term scarring results. Again, is lung damage reversible? Yes, sometimes it is, but even if it's mild disease, that reversibility is not overnight. Patients don't get off the ventilator and all of a sudden they feel better and they just recover. It takes weeks, months, and there's even some things that talk about, some studies that are suggesting that it's going to take a year for the lung disease to clear up. And again, so you need to set those goals with people, with them understanding that this isn't going to be a short course. This will be a longer course related to this. And again, factors that affect whether or not they have really severe disease versus only having mild, or whether or not they're going to actually get long-term effects of it, is whether or not their case is mild or severe, what kind of treatment they got, and even the other thing that you have to think about is what are their underlying health conditions. If they already have COPD or asthma or other health conditions, then they're more likely to get the lung damage that will be long-term. Growing number of people are starting to have, like I mentioned earlier, still continuing to have breathlessness and coughing even months after their illness. And you'll see on the CAT scan about the fibrosis. And so we have to be prepared in the future for taking care of these patients. I'm going to skip this just for time purposes, but I wanted to get to things that we can do to help our patients who develop those long-term lung problems. There are some things that we can do, and these patients, as we're seeing them, we can help them on an outpatient level with helping them with feeling better. One of the things that we can do is teach those patients how to do breathing exercises. Those are the lung expansion, where you're teaching them to inhale at 1, 2, and then exhaling. We also have proning that patients can do that aren't really sick. Proning can actually help open up those lungs. And that's because, remember how we talked about the fluid building up in those air sacs? Well, proning can actually open those air sacs back up once they've collapsed on each other. And we'll also talk about incentive spirometer and teaching patients to utilize incentive spirometer. And I wanted to just show a picture of the incentive spirometer. Incentive spirometers can really help those patients with building their muscles and doing those breathing exercises while they're recovering from COVID. Proning has been something new that we do. Proning usually is dedicated to healthcare providers who are taking care of really sick patients on ventilators. But what we found is that awake proning these patients can actually help as well. And so patients who aren't really sick that are at home, you can talk to them about proning themselves to see if that will help them feel better. And again, you're giving those air sacs that are collapsed a time to reopen. The idea, and I try to answer a few questions, is how long should they prone? And the answer is as long as they can tolerate it. Patients usually can't tolerate being on their stomach for very long. And so maybe setting shorter goals like 1 to 2 hours, or as long as the patient can tolerate. And again, these are patients that are at home and can easily prone themselves, and you can kind of help them with them. If they're in the hospital, these are some things that we do as well with proning them and monitoring them. If your patient's really short of breath, breathless, having a lot of breathlessness, having a lot of problems with that, then you don't want, you don't want to encourage them to actually do it. I was looking to see how long is the ideal, because I anticipate somebody going to say, well, how many hours a day should they prone? And they say 16 hours, but you're not going to get somebody to prone during that period of time. I didn't go into a lot of details about proning, but I can give you some more information on that, the details on it. Again, you're really sick patients. You don't want to do this. These are just patients who can actively prone, and if it's making them feel better, then that will be great for them. Finally, well, not finally, but one of the other things that we can do is using your finger pulse oximeter. One of the things the Nashville area did was purchase several finger pulse oximeters and gave them out to healthcare providers that we are actually able to send patients home with these and allow for patients to monitor them. There are a lot of other areas. I was reading recently that the Alaskan tribes have actually done that as well for those people who are out in those remote areas as a part of them being able to monitor themselves. One of the things the Nashville area did was to develop a patient handout related to use of pulse oximeter and how to use it and how to correlate it. So that's available should you all need it or want it, just as we are moving forward with pulse oximeters. They are difficult to find. They're becoming a little bit more difficult as this information is now becoming very popular. I did talk to some of the tribes that are actually, I think it's Miccosukee is actually doing a COVID packet for all of their tribal members, and a part of their COVID packet, they're including thermometers as well as pulse oximeters. So. Let's talk about in general, how can we follow up with these patients, not as a healthcare provider, but as just in general in public health, helping these patients to get through it, checking on them to make sure that they're okay. Again, we are all in this together. It's so important that the community actually gets together and checks on these patients. And that doesn't mean going to their house. It doesn't mean showing up at their door. That would be great, but you can call and check on them or text them, other ways of checking on them so that you don't have contact with the patient. These are just some suggestions on time frames. One of the things with COVID is that while they may feel good at the beginning, as time goes on, they start to feel worse. And so some of the things we talk about, when do we need to follow up with them or making sure that we follow them up. And for the average person, maybe on the first day, you're following up, making a phone call. If you're really, really busy, you have other things to do, or if you're doing home visits, maybe you're doing day 5, or if it's really high risk patients, then you really want to follow up a little bit more, maybe on day 4, day 7, day 10, as well as a couple of days after they're discharged from the inpatient if they've been in the hospital, as well as if they have to go to the emergency room because they're not feeling as well. Follow up a couple of days after that would be wonderful. Those particularly high-risk patients, which I'll talk about, or patients who are having a really difficult time where you've talked to them and they're still having a difficult time, you may want to follow up with them more frequently. Our high-risk patients are our patients who are 65 years or older, those who have underlying medical problems like high blood pressure, COPD, asthma, maybe getting chemotherapy because they have cancer or HIV, patients who are severely obese, if they have chronic kidney disease or chronic liver disease. Those are the ones that we are considered high risk. And so what are some questions that you can ask when you make these phone calls with the patient? Well, try to assess them for their problems with breathing and if they're having a low oxygen. Again, ideally, they would have a pulse oximeter. And so you would ask them to measure their pulse. What is your pulse oximeter been running? If they're saying consistently, you know, when I first got this disease, it was 99%, now I'm down to 93, 94, then you may want to be encouraging them to go to a medical provider. You may want to call your doctor's office and let them know what's going on so that they can tell you if there's something else you need to do. Also ask them about, you know, whether if they're feeling a little winded, ask them if those are affecting their ability to do things daily, like, can you take a shower if you take showers normally? Are you to the point where you can't go to the bathroom because you're so short of breath? They're telling you, hey, I start to the bathroom and I actually have to stop and rest halfway through. And those should be concerning signs that, you know, something may be going on. And I have a typo here. It's supposed to be putting on clothes, and if they're putting on their clothes and they feel short of breath where they can't only get their shirt on, those are things that are concerning that you want to encourage them to go to their provider. Asking them if they have that pulse ox or a blood pressure machine, what is their heart rate being? If they're consistently saying my heart rate's in the 140s, I'm feeling like my fingers are blue, my lips are blue, or if you're talking to them and they're having difficulty with actually having a complete sentence, then there is a concern. And so you should be saying, hey, you may want to reach out to your medical provider just to let them know. If it's really bad off, you may want to, you know, have them call the emergency department. Also, you can assess while you're talking to them about their alertness. If you're asking them questions and they're easily distracted, or they're asking you over and over again, what did you say? That's a concern, because maybe that's affecting their alertness. If they're telling you they've been in bed all the time, they're extremely sleepy, extremely tired and fatigued, those are things that you should be encouraging them to go to healthcare providers. If they have recent falls or felt like they were about to pass out, those are some of the key things that you should be in tune with to encourage them to seek more care. If they talk about having chest pain, one of the things with COVID is you hear about all the clots that they have. Those clots go to your heart as well as your lungs. And so patients who have chest pain, they may be having a clot to their heart. They may be having a clot to their lung, what we call a pulmonary embolus. And so those are things where you should be having them to seek treatment. And that's definitely something that they're saying, I'm having chest pain or really bad chest tightness. That's when you need to tell the patient they probably need to call the emergency department to get more guidance on presentation to the emergency department. The other thing I want to mention is if your patient has a pulse oximeter and maybe their oxygen level's a little low, maybe like 94%, and they're telling you, hey, when I go to the bathroom, I'm just really winded and I have to stop and take a break, ask them to actually measure their oxygen level while they have walked for about a minute. Usually there are a lot of patients who, you know, their oxygen level may be borderline at the beginning, but when they walk, their oxygen level significantly drops. And so having that patient to maybe walk around the house for a minute and check. And if their pulse oximeter is dropping significantly more than 5 points, or even if at any point that oxygen level drops less than 92%, I would be encouraging them to seek treatment. Now, if they tell you that I've been to the doctor multiple times, this is my norm, then that may be where they are and they may be stable in that area. But if this is something that's new, then you really need to be encouraging them to seek treatment. And that's probably how the mortality difference for COVID will be when we're talking about outpatient, is people understanding when to seek more treatment. A lot of times people feel like, I just feel bad and, you know, this is just a part of the disease, which a lot of times it is, but there are times where that's not a part of the disease and they really need to be looked at closely, because some of these things may be the first sign that they're starting to develop lung disease and need oxygen and need to be monitored more closely, as well as being started on medications. I'm going to end this with talking about some of the resources for patients. For those of you who do home visits or maybe being able to email patients information, I wanted to share with you some of the resources that are available. And these are some resources to help keep patients safe. These are on the CDC website as well as other places. If you like the links for the resources, just let me know and I can get them for you. One of the resources that I mentioned earlier was about the finger pulse oximeter that I can share, and that's a guide for the patient to take home with them so that they can measure their oxygen level as well as correlate, because sometimes those pulse oximeters, your fingers are really cold or something else is going on where you have fingernail polish on or some reason why that pulse oximeter is not reading correctly. And so that patient needs to understand that, hey, maybe the pulse oximeter is not reading correctly, so they're not running to the emergency room or to their doctor's office every time they get a low reading. But they also need to recognize that, hey, this is a real reading, and so therefore I need to seek further treatment. And so this resource will go through some facts about it as well as the actual procedure for checking their pulse oximeter. Also, there are some general community handouts that talk about ways that germs are spread and how to avoid that. There are some hand washing handouts that the CDC has about hand washing and hand sanitizers and how to use them. And those, again, those are on the CDC website. And providing them to your patient or your friend or your family member may be very helpful for them. And also something I want to mention, especially for those at risk, about wearing masks. It's so important to wear masks. Masks not only keep you safe, but it keeps everyone around you safe as well. And so teaching them about how to properly wear the mask, how to take the mask off, all of those are some resources out there that will help them with that, talking about cleaning your mask and when you should be using them, as well as some guidance on cleaning and disinfecting their homes so that they can avoid other illnesses. Because yes, you do need to kill COVID and clean those surfaces for that, but also you don't want someone who's sick also because we're at home more getting a bacterial infection because we're not cleaning surfaces and we put our chicken there and we now have an E. coli infection or other surfaces. Remembering that not only for COVID, you want to clean surfaces for COVID, but you also don't want someone who is at home and get other bacterial infections as well. I think this concludes my talk, unless we have some questions that people have as follow-up.
Thank you, Dr. Johnson. Do we have any questions for Dr. Johnson? If not, we can move on to Dr. Mira.
Okay. Okay, good afternoon, everyone. So today I'm going to very briefly in one slide address the efficacy of wearing masks, just as giving the big picture, not going into any details. And I'll focus on evaluation of symptoms, evaluation of asymptomatic patients with negative COVID-2 PCR, which has become like a frequent question in our system, and I'm sure that you have the same issues. And just give you some perspective of how we should address this. So regarding the mask, the efficacy of masks, this is just comparing on the top slide, you will see the daily new cases of COVID-19 in New York. And on the bottom slide is the same thing, but compared to the United States overall. And this was published in the National Academy of Sciences last month. And you see the different interventions that were done and the association with the impact of the intervention. You know, causality here is not straightforward because there's other confounding variables, but this is basically as good as it gets. So as you can see in New York, when they implemented social distancing, there may have been a mild impact. Stay at home basically plateaued the curve, but it was not until face covering issued by CDC recommendation that there was an associated decline in the number of new cases. And when you look at the United States overall, you see that stay at home did the same thing that did in New York. It kind of plateaued it, but since there's not an enforcement of the face covering or wide adoption overall, we still are not seeing that decline. And I think that's a very important, Dr. Johnson mentioned that, but that needs to happen. I think it should be mandated that people in public places wear masks. This seems to be the most impactful intervention we can do. So let's talk a little bit about symptomatic patients with negative SARS-CoV-2. So important definition. So SARS-CoV-2 is the virus that causes the pandemic. But SARS-CoV-2 infection is when you have ongoing viral replication in the body, and that can be detected in 4 different scenarios. It could be detected in asymptomatic individuals. It could be in pre-symptomatic individuals. You know, they come for random testing, but then 3 days later, the test is positive, and a few days later, they become symptomatic. And of course, it can be detected in symptomatic persons. And also, we see it detected in persons who are who have been symptomatic, and they're not symptomatic anymore, and they still test positive for the virus. The important thing is that in all of these categories, in general, patients can be safely released from isolation 10 days after the first symptom occurred, or 10 days after the PCR test was positive, in case this was an asymptomatic patient that was tested or a pre-symptomatic patient that was tested. So when we're talking about symptoms related to COVID, these are the ones that have been reported, headache, cough, sore throat, shortness of breath or difficulty breathing. GI symptoms are fairly prevalent, more than what we thought, maybe around 20 or 25%. Fatigue, muscle or body aches or fever, chills, and then congestion or runny nose. And what is pretty frequent is a new loss of taste or smell. So if you're like in the outlying setting on a clinic, when you look at symptoms of patients who did not require hospitalization, headache, loss of smell, and nasal obstruction are pretty prevalent. And then you have the rest of the symptoms going down the list. As you can see here, shortness of breath is not a major symptom. And this is taking all patients that tested positive for COVID-19. There are some differences according to age and gender. So ear, nose, throat complaints are more common in young patients, fever, fatigue, loss of appetite, and diarrhea in elderly patients, and loss of smell, headache, nasal, upper respiratory symptoms, and fatigue are more common in women, and cough, fever are more common in men. Now, this is just saying more common does not mean that because you have one, it excludes the other. But if you're looking at hospitalized patients, this changes a little bit. So in the blue columns are the patients who had a positive symptom. Orange is they did not have it, and green is that it wasn't documented or unknown. This is a study that looked at 16,000 patients. So on patients who are hospitalized, cough, fever, shortness of breath, and fatigue are the major symptoms, more frequent symptoms. And then you have all the rest of the symptoms that decrease in frequency. And this is just a sicker population because they are getting admitted to the hospital. So these are two patients that we had last weekend in our hospital. The first one is a 44-year-old female. She had a one-day history of shortness of breath, cough, myalgias. She has diabetes and COPD. Her coworker had tested positive for COVID 10 days before that she came to the hospital. And her lab showed lymphopenia, D-dimer was normal, procalcitonin was normal, CRP was elevated, 77, and the community-acquired pneumonia workup was negative. When I mean CAP workup, it includes blood cultures, multiplex nasopharyngeal PCR that detects 14 plus viruses and other bacteria, and pneumonia panel if they produce a sputum. It also includes Legionella antigen in urine, pneumococcal antigen in urine. So it's a very thorough workup, as good as it can get, and it was negative. The other patient is a 23-year-old male, had a 4-day history of shortness of breath, cough, nausea, vomiting, diarrhea, and headache. He also has risk factors for severe COVID disease if it happens, diabetes and asthma. Mother was tested positive 1 week ago, so both of these patients had a exposure history. Labs, no lymphopenia, but the D-dimer here was elevated. And again, very similar to the other patient, normal procalcitonin, a CRP that was elevated, and a completely negative pneumonia workup. And if you look at the CT scans, as Dr. Johnson was mentioning, these are pretty typical ground glass opacities, maybe not as peripheral as we would see them, more central than peripheral, but these could be associated with COVID, and that's what the radiologist reported. This is the other patient with, again, ground glass opacities bilateral. So the question to you, the audience, is which of these patients has a positive PCR for COVID-2? And I'll let you think for 2 seconds, and then I'll give you the answer, and the 2 seconds are up. So the one on the right has a positive PCR. We did 2 PCRs on each patient. We do an Abbott test, and we do a film array, which is a nasopharyngeal multiplex PCR that includes COVID, SARS-CoV-2. And the one on the left had the 2 tests were negative. So the next question is, which of these patients have COVID-19? Same patients, and the answer is, by case definition, both of them have COVID-19. So this is where the questions start, and the providers are a little bit puzzled. Which one do we put in airborne isolation? Of course, the COVID-19 positive you do, about the other one, but they both meet case definitions. So what is the case definition? So I'm showing you the WHO, which is very similar to the CDC. The CDC is a little bit more complex, but basically it says a patient with an acute respiratory illness, fever, and at least one sign symptom of respiratory disease, and one of the following. And when you look at one of the following, both of these patients met number 2 and 3, which is contact with a confirmed or probable SARS-CoV-2 infected person, which they both had, and they both required hospitalization. So that meets the case definition. And the other parameter is history or travel to a residence in a location reporting community transmission. That in the United States, it's basically every single state, some more than others. So why are we having these problems with our PCR? Well, normally the FDA requires 2 criteria to approve any test, any diagnostic test, to be FDA approved. One is analytical performance, and that's basically using in vitro laboratory techniques. And to give you an example, they will spike virus into a sample or a test tube, and then they would see that if the test that they are trying to validate, let's say it's the Abbott test, what is the sensitivity to pick up that virus, and how specific that can be? Meaning, if I don't put the COVID virus and I put influenza virus, will the test be positive or negative? So that's called analytical sensitivity, analytical specificity. It does not require any patient sampling or patient information. And the other, which is very important, is the clinical test performance. And this you can obtain from natural clinical specimens, like you're swabbing a patient and you're defining that patient by some parameters as being COVID negative or positive, and then you validate the test that you're evaluating at that moment. For example, this lady, we can say she has COVID because she has fever, cough, etc., and also has a positive PCR, a standard positive PCR. And now I'm testing the new PCR test, call it the Abbott or whatever, and we are seeing how that test performs against our reference standard. And the reference standard should be clinical plus minus laboratory information. So, well, the problem that we're having is that most of the tests approved by emergency use authorization are using analytical performance, but not all of them have clinical test performance. And the ones who do have clinical test performance, many of them are doing on not real patients, but a sputum from a patient that does not have COVID spiked with virus, and they're using that as a sample. So the issue is that we're not having the standard of diagnosis or for approval as we are with any other test. So there's many studies published looking at sensitivity and specificities. I think this is the best one that I've read. It's published in Annals of Internal Medicine. They reviewed 7 publications which were included in their analysis, and those publications to be included had to have data on RT-PCR correlated with time since symptom onset or exposure of the patients that were being tested. They evaluated over 1,000 patients with tests, and they had a reference standard. So the reference standard was having at least 1 positive PCR in the clinical course of that patient. And some studies also included a clinical definition in combination with detectable antibodies for SARS-CoV-2. So let me explain this graph on the right. So this on the x-axis is days since exposure. And considering a 5-day incubation period. So here where you have symptoms start, that means that 5 days have elapsed since the patient has been exposed. So if you do a PCR the day that the patient is exposed, 100% will be false negative. So on the y-axis is probability of a false negative test in a patient who actually has COVID-19. So if you go to 1 day before the symptoms start, the false negative rate is 67%. And of course, course, the confidence intervals are pretty wide, but this is the average of a false negative test. If you test the patient the day of symptoms, you have an average of 38% of false negative tests, and your best shot at getting the lowest false negative rates is 3 days after symptoms start, which is 20% of false negative tests. So, and the confidence intervals here go from 10 to 30%. So this is the best we're going to get with any test we use, is about around a 20% false negative rate if we do it in the best time, which is a few days after the symptoms have initiated. So this is why it is useless to test contacts of people who have COVID if the exposure has been within a few days, if you're seeing the patient within a few days of the exposure. So a PCR will probably be negative, and that does not mean that the patient doesn't have COVID. So when we have these imperfect tests, a negative result means only that a person is less likely to be infected, not that it's not infected. This is in contrast with molecular tests that we use in our clinical practice, for example, for influenza, which have a 98% sensitivity, or for hepatitis C, which have 99% sensitivity, or for HIV, which have 99.6% or 99.9% sensitivity. So we are used as providers to having tests with a very high sensitivities that can practically exclude a diagnosis. In this case, we can't. So to determine the likelihood that a person that is infected with COVID-19, to determine the likelihood that that person is infected, you need information not only on the test, but about the person also. So the pretest probability is the estimate of the person's chance of being infected. And there are 3 parameters that are needed. First, what is the local COVID-19 prevalence in the community that that person is? 2, what if the patient has an exposure history or not? And 3, if the symptoms are compatible with COVID-19 or not. And then you have to plug in the sensitivity and specificity of the test that you're using. And ideally, that information is also stratified by other variables like what is the specimen. The sensitivity of a test will not be the same in stool, sputum, nasopharyngeal, nasal, etc. The timing regarding the exposure or the symptom history, and also the illness severity. And all that information, unfortunately, we do not have it for every test that's out there in the clinical practice for COVID-19 today. So this was published in New England Journal of Medicine not too long ago. And in the x-axis is the pretest probability. So here, if I'm here where the arrow is, that means that this patient that I'm seeing has a 15% chance, a 15% pretest probability of having COVID-19. And if I use a test that has a 70% sensitivity, which is basically more or less the test that we are using, and if the test is negative, there's a 5% chance, this is where the blue line intersects this dotted line, 5% chance that will be a false negative test. So if you're willing to live with the 5% false negative rate, then that test would give you some information. But if the patient has a 25 or 30% pretest probability, then the false negative rate, it goes up to 10 or 12%, which is probably not acceptable. If you have a test with 90% sensitivity, on which this is the green line, and the patient has a pretest probability of 35%, then the chances that a negative test with this characteristics is negative will give you a 5% false negative rate. But if the patient has a 50% probability of pretest probability of having COVID, then it goes up to 10%. So this gives you an idea of how important the pretest probability is in determining the likelihood that a patient's infected or not. The problem is that we don't have yet a good way of estimating an individual patient that we're seeing in our clinic, what is the actual pretest probability, giving it a number. There are some calculators out there. Some have local validation, but we don't have one that we can recommend right now for general use. So the IDSA came up with some guidelines. That's the Infectious Disease Society of America. And I'm not going to go through the whole chart, but if you have a high suspicion for COVID, meaning a high pretest probability, even if the patient is not hospitalized or hospitalized, if you look at what you have to do at the end, it's the same thing. If the test is negative, you repeat it. If negative, repeat it. If negative, repeat it. So a negative test does not tell you the patient doesn't have it. And even a repeat test, a negative repeat test does not rule it out. Now you have a low suspicion of COVID-19, then if the test is negative, you probably can live with that result and say you most likely do not have COVID, and you give them the recommendations based on that diagnosis. So I have 2 more slides. The conclusions of all those studies is that diagnostic testing will help in safely opening the country, but only if the tests are highly sensitive and validated under realistic conditions against a clinical meaningful reference standard. And as of today, we don't have that. The FDA should make sure that manufacturers provide all the details of the sensitivity and specificity, how it was obtained, because you will read on an insert saying the test has 90% sensitivity, but when you look how they got it, it's probably not with a clinical reference standard. That was probably an analytical sensitivity. Then we don't have no data whatsoever on what the test sensitivities in asymptomatic people are, and that's needed. And like I mentioned, developing methods of estimating the pretest probability for asymptomatic and symptomatic people is crucial, or else it's very difficult to interpret what is the likelihood that a negative test means that that patient really doesn't have the disease. And negative results, even on highly sensitive tests, cannot rule out infection if the pretest probability is very high. So clinicians should not trust unexpected negative results. They should assume a negative result is a false negative in a person with typical symptoms and known exposure. So what are we doing in Cherokee Nation? So this is what the algorithm that we came up with. So this is for patients who are symptomatic, they have COVID-like symptoms, and their PCR is negative, or their whatever, the PCR, nasopharyngeal, nasal, whatever you're using is negative. So if the patient has high probability, and that's defined as a known exposure, or history and symptoms consistent with COVID with not an alternative diagnosis, then you consider them COVID positive and you isolate them for 10 days. This is like the person I showed you, the CTs, the one on the left, had everything compatible with COVID, but the test was negative. If you have a low probability, that means that you do not, the patient does not have confirmed exposure, and the symptoms can be explained by something else. I'll give you a quick example. The other day I saw a young lady came in, she was triaged to our COVID clinic because she had a fever. When she came in, she had dysuria, flank pain, she had pyelo. And she was tested, because everybody who comes to the COVID clinic gets tested. COVID test was negative, but there was low probability, and we just consider her COVID negative. And the problem is the moderate one. Moderate one means there's not an exposure, but the history and signs are not clear, and you really can't rule out any other infection. So here we said, well, consult infectious diseases to evaluate the case, and if that consultation is not available, consider the patient has high probability. One caveat is that patients with asthma, COPD exacerbation, dyspnea, or abnormal chest imaging should not be never considered a low probability. They always fall into moderate or high categories. And I hope I didn't confuse you, but I did my best there to try to clarify this. This is just a final thing. I would recommend that everybody reads this. It's a correspondence published recently in New England Journal of Medicine, and the title is Contact Tracing for Native Americans in Rural Arizona. It's a very inspiring piece, and it's a short read. And the last sentence that the authors published was, COVID-19 is a novel disease in need of novel approaches, but our experience has shown that there is no substitute for providing services according to the most basic principles of medicine and public health. In our current healthcare system, knocking on doors and talking to patients may be the most novel approach. And I'm not going to spoil it for you, so I won't give you the details of what it says. You just have to read it. And thank you very much.
Thank you, Dr. Mira. There is one question. What is normal CRP for your lab?
Less than 5 in our lab.
Okay. Any other questions for Dr. Mara? Emily just posted the survey link, so if everyone will take a moment and fill out the survey, it's very short. It'll help us guide us to what we need to do for next echo. Thank you all. Have a great Friday and great weekend.
Bye-bye.
Thank you.